Hello, everybody, and welcome to the Better You podcast. I'm joined by Ravi Patani and Dr. Tracy Tilton.
Hi.
A big thank you to both of you for joining us, as well as a thank you to our sponsor, Lamco Wellness, for sponsoring this. Um, Today, we are talking about borderline personality disorder, um, which I know very little about. My only experience with it is I had a friend in high school who had it, and that's about it. So I'll kick it over to you, Dr. Tilton. Tell us about this.
Okay, so borderline personality, the DSM diagnostic criteria is that someone has a pervasive pattern of unstable interpersonal relationships, unstable self-image, and unstable affects, and it's marked by impulsivity. Has to start by early adulthood and be in a variety of contexts. Um, And to be diagnosed with that, you have to have five or more of the following criteria. One is frantic efforts to avoid real or imagined abandonment. Um, they tend to either like they put someone on a pedestal and then they devalue them. You're with me or you're against me, kind of very dichotomous thinking on their part. Um, a pattern of unstable and intense interpersonal relationships, again, alternating between extremes of idealization and devaluing somebody. Identity disturbance, markedly and persistently unstable or sense of self. Impulsivity in at least two areas that are potentially self damaging, like spending, promiscuous sex, substance abuse, reckless driving, binge eating, gambling, any of those kind of things. They're just being very reckless in their behavior in those areas. And then recurrent suicidal behavior, gestures, or threats, and that includes self mutilating or self injurious behaviors such as cutting, burning yourself with cigarettes, banging your head against the wall, literally, not metaphorically. So, some stuff that has really the potential for serious injury, if not death. Um, Affective instability um, due to marked reactivity and mood. So this would be intense episodic depression or dysphoria, irritability or anxiety that lasts. All those last in just a few hours, not days like it would in if it was bipolar, or days or month, bipolar. Chronic feelings of emptiness and inappropriate, intense anger or difficulty controlling your anger, like frequent displays of temper, like we call it borderline rage, where someone gets so angry they almost appear psychotic, um, and then like or recurrent physical fights. And then the last one is transient stress related paranoid ideation or severe disassociation symptoms. So these people can be quite a treat. They are the kind of person or client that when another clinician calls you and says, I'm referring someone to you, and they happen to be borderline, you're like, oh, why do you hate me? What did I do to you to make you refer to this kind of person? Not that they can't be like nice people as well, because they can't be, but they just have so much going on interpersonally and just this unstableness that just is so pervasive that it makes it hard to work with them. Though they are treatable. This is one, several like antisocial personality, not treatable. But this is treatable. And I'm going to get to how it's treated in a few minutes. Um, the estimated prevalence of bipolar is 1.6% to 5.9%, with a widely cited median of 2.7%. So yeah, you're on mute. Okay.
Sorry, 2.7% of people have this
Yes,
estimated.
yes.
That's a lot of people. That's a whole lot of people.
That's the median. It could be a little bit more. So in a clinical setting, the prevalence is, well, in primary care, like say you're just at your, PCP's office and they're like, notice, that some things are maybe not quite, I don't want to say not right, but there's some stuff going on with you and they screen you and they screen through their screenings, they get roughly 6% adults who they classify as borderline and refer for further assessment. So in the outpatient psychiatric clinics, they make up 11% to 12% of people in that clinic. And then in inpatient facilities, the prevalence peaks at 20 to 22%. So a lot of these people are hospitalized at least once, if not more frequently. So for gender, this is, well, the first statistic is mind-blowing, that close to 75% of people individuals diagnosed with BPD are female. Now, in the general population, they say it's 1-to-1. So the explanation for it being so much more in the clinical setting is that maybe women tend to be referred or seek treatment more than men. So that accounts for the, major discrepancy. So then in clinical settings, comorbidity is the rule, not the exception. 85 to 95% of people who have borderline personality disorder also have another psychiatric disorder. And the median for that then actually is at least, by people who meet the criteria have an average of 4 co-occurring disorders. So the rule is that they have one, that they will have one, and then people who do have that have an average of 4.
So is there a thing where bipolar disorder and borderline?
There is, and I'm going to talk about it when we get to differential diagnosis, because those are the two most commonly mistaken for each other, because the mood swings are so the mood swings with borderline personality disorder are so severe. But I mean, the main difference is they just don't last as long. They cycle in and out like an hour, 2 hours. While the bipolar people, they can go weeks, months, years cycling. Yeah.
I did want to, because do the symptoms abate, or is it just always, because I'm thinking of the person who, and for all I know, they might have just said they had borderline personality disorder, but the person I knew who told me hey, I'm diagnosed with borderline personality disorder, they were chill, normal, and then there'd be a week to a month where they were just overly emotional about everything. And I remember that there was at least a month where they just weren't around because the symptoms had gotten that severe. But there were a lot of times where I could talk to them and it was a normal conversation.
Yeah, no. And that, that can absolutely happen. I mean, it did for you. And it's not that they're always, nightmarish in their presentation. It's that, they have these swings, and it's where they're just, they're so unstable across the board that means they can not present with these, all these criteria, but then, something happens. It's cued by an external event. Bipolar is usually an internal event. So that's a big difference. So there's a lot of externalizing with people with borderline personality disorder. And so some of the co-occurring disorders that happen most often is, first are mood disorders like major depressive disorder that affects 60% to 83% of individuals with BPD. So that's the major one. And then bipolar, approximately 15% of individuals with borderline also have bipolar. And then anxiety and trauma disorders. People tend to think of people with borderline as having absolutely had a very traumatic childhood or some sexual trauma. And that's not the case. And it can be the case, but it's not across the board that happens. But they do have 88% of individuals with social anxiety also have BPD. But they also can have generalized anxiety, panic disorder, and the like. And then PTSD, occurs in 35 to 50% of cases, which are heavily tied to high rates of childhood trauma. So not as much like war, combat or things like that, obviously, but childhood trauma. And then in terms of what, like the etiology, if your first degree relatives, if a first degree relative has borderline personality disorder, then you're much more likely to have it as well. Also, because it's not genetic per se, but you inherit some of their brains. They have different brain structure and functioning than people without it. Specifically the amygdala, which monitors emotions, risk, fear, violence, and the prefrontal cortex, which monitors like impulsivity and things like that. And they have structural abnormalities in those two areas of the brain, and then you combine them, and it's not a pretty picture. And that accounts for a lot of their like rage, anger, everything like that. Also, they might not have enough serotonin in their brain, and that the lack of that neurotransmitter impacts their mood and impulsivity as well. Let's see what else. Oh, chronic mistreatment as a child, inconsistent caregiving, neglect, any sexual abuse, all of those also contribute to it. When you're, before your personality is fully formed, these things are happening. So then it doesn't go down the normal road that most people's does. Like your functioning doesn't go down the normal road. Go ahead. No, go ahead.
So I wanted to ask in terms of the broader world of psychological disorders. One of the things that I've noticed in talking to my own clinicians and also the conversations that we have is that and this appears to be an exception, but not entirely. For a lot of these disorders, it seems that there's a core biological function, and then there's some sort of trauma that seems to trigger it.
Yeah. It does, not all of the time, but I don't say much of the time, but sometimes let's just say sometimes it does. And the trauma is usually inflicted by a parent, not like a neighbor or a friend of the family or anything like that. It's usually like parental, because it's more consistently happening, which makes it more likely to develop into borderline personality disorder.
Okay. And I was speaking not just for this, but it does seem like it relates to this as well. But it seems like a lot of disorders in general, like there's a core biological component that the person might have, and then there's trauma, and then it turns into X, Y, or Z.
Yeah, no, I would agree with that.
Okay.
Yeah, I think that's accurate.
Key lesson being try not to traumatize people.
Right. Yeah.
So sorry, Dr. Tilton, there's no like exact cause of BPD. Is that
no?
correct?
There's not just like one thing. It's not like you inherit a gene that makes you have it.
And then so you would say that like that's the big difference in terms of like bipolar disorder, where there is like it's like linked to genetics in a way.
Yeah.
Okay.
Mm-hmm. Yeah. And I'm going to go into differential diagnosis now. And it's essential to really look at differential diagnosis, because so many of the traits of borderline overlap with, like, say, the mood disorders, PTSD, the ones I had just mentioned that a lot of them have. The major one is bipolar disorder. It's one of the most common challenges in clinical evaluation. Like, you need to have really good notes, hopefully, on this person, because otherwise it can be in like the timeline of when things are happening. Because in bipolar, mood shifts are driven by sustained internal neurochemical, like neurotransmitters. Mood shifts are sustained, and they last days, weeks, or months, like I mentioned, and they're largely dependent on external events like you fail out of school, or it doesn't even have to be anything that major. It could just be, you had an argument with your boyfriend or girlfriend, stuff like that. With borderline, it's more internalized, and it's, you are saying, you're thinking to yourself, like, say you get in a fight with a boyfriend or girlfriend, and then you have this intense, extreme fear that they're going to abandon you. And that's then when they go between, idolization or idealization, thank you, and devaluing somebody. And then they can be real nasty. One of the more famous books is I Love You, Don't Leave Me. I Hate You, Don't Leave Me. And it's about borderline. And it's like, I think everyone who's ever gone through psych grad school, whether it be master's, PhD, whatever, has to read that. Probably in undergrad psych too. It's just a classic. And then another really good one is A Life Worth Living, which is by Marsha Linehan, who created DBT, which I'm going to talk about in detail. And that's a treatment that does work for borderline personality disordered people. They're both really worth reading. So then you look at the differential diagnosis between major depressive disorder and BPD. And again, depression is marked by pervasive state of low mood, anhedonia, which is when you don't enjoy things the way you used to enjoy. And it's kind of the hallmark of a depressive disorder as well. And borderline is characterized by distinct chronic emptiness and an intense anger. They just don't have a completely developed sense of self. And then that's related to the emptiness. So, and also with, not wanting to be abandoned or feeling you're falsely being abandoned, is that a lot of times they think when they're with someone else, it like completes them. So when that person might leave, or there's a threat of them leaving, whether it's misperceived or not, they kind of fall apart because they need that external person to help them feel like they have a sense of self and they have an identity. So, yeah. Did you have a question, Aaron?
So, yeah, I'm because this seems like a big issue specifically in relationships. It can obviously be an issue in a lot of things, but it seems like it would be very difficult to deal with as somebody in a relationship or as somebody in a relationship with somebody that has borderline personality disorder. And I feel like I remember in my own life and also the lives of my friends and family where I'd be in a relationship, they'd be in a relationship or whatever. And at the time we're just like, oh, this other person is just crazy and, they're terrible and you should break up with them. And then the vast majority of the time, years later, after it's ended, we can kind of come back and go, no, it's just a really bad relationship where we both brought out the worst in each other. And it seems like in this case, it's both. Like it is probably both of those things. If that makes any sense.
Yeah, they are not easy people to be involved with on friendship or romantic relationship level, or family or friends. They just across the board, they are very unstable and just have a really hard time being consistently involved in a relationship in a healthy way. They just can't do it. And then another differential diagnosis is borderline personality disorder versus narcissistic. And narcissistic, as we know from a podcast we did last time, I think, features grandiosity and also lack of self. But borderline, their lack of self and their immense emotional pain causes them to do like the suicidal gestures, whether it be cutting or whatever, or threats of suicide or actually attempting suicide. So they have kind of a different way that they show up. the two different disorders. So the best way to assess it using evidence-based scale is the SCID, Structured Clinical Interview Diagnostic, and they have one specifically for personality disorders, which is really, it's like the gold standard. And then they have the DIBS-R, which is specifically for borderline personality disorder. So there's two really good tools that you can use for assessment. Of course, you might already have a really good idea that they are by the time you get to the assessment phase with them, but not always. So then there's also the BSL-23, which is like highly specific questions for borderline personality disorders. So that's a good one. It has a little bit less research on it than the other two, but it's still a good measure worth checking into. Yeah.
Sorry, I just have so many questions because I feel like
ask away.
2% of the population is like, it doesn't seem like a lot, but that's a whole lot of people.
Yeah.
And two, I feel like now I'm just totally doing what you're not supposed to do and diagnosing all these people I've never met, or I have met. But one of the things that you talked about, I find interesting, just because I can kind of see this happening, where like somebody who has narcissism, it might benefit them to be seen as somebody with borderline because it enables the manipulation a little bit more in terms of like pity and things like that. Is that something that happens?
I don't know that I've seen that personally. I can see where you would think that, because they are both manipulative, but narcissists are more manipulative, like with their words, while borderline is more with their actions and their behaviors.
Okay.
Because again, they tend to externalize, while most of the other disorders internalize.
Okay, that makes sense.
Yeah.
And like, how do you diagnose, right, when a patient comes to you and they don't know for themselves, they don't know what they're going through, but like what is the differentiation of like diagnosing that person with, okay, if it's BPD or like bipolar or narcissism?
What would you say? What's the?
Well, like, how do you diagnose them? Like, how do you know?
Oh, how do you diagnose it?
Yeah.
I'm sorry, my dog just walked in.
No worries.
Miss. Sorry.
Okay.
He just got home from mini camp, so he's
Oh,
very
nice.
excited.
Nice.
But yeah, I mean, in terms of diagnosing them compared to other people, the biggest factor is just doing the really good diagnostic interview, which it is in any case, diagnosing any disorder. But then, using a formal assessment would be the second really most important thing. So it's doing a very thorough interview assessment and then pulling all that data together.
Okay.
That's really the best way.
And what does that consist of, that assessment? Like, if you can like give an example of like one or two questions.
Yeah. Let's see. A question might be, when you lose a person in your life, how do you tend to react? Or, with anger, sadness, something along those lines.
Okay.
Another one might be, straight up asking, do you do suicidal behaviors? And if so, how frequently? Because those are really dangerous for obvious reasons.
Yeah.
And then they cut because it's a release. This is what I've heard from my clients. They're cutting because it's a release from their emotional pain. So the physical pain takes away their emotional pain because they have something else to focus on. So it's a really short-term solution, and it's not a very good solution because there's so much potential for death or danger. But that's really, really common. And that's what I've been told. That's why they do it.
I also feel like you really have to meet them in the present, where like if whatever they're thinking or whatever they're going through in the moment, it's going to be a big of a difference how they were like 10 minutes ago or like an hour ago.
Yeah, I mean, they change it quickly.
Mm-hmm.
Like you'll be having a rational conversation with them, and then they don't like what you said, and this rage comes out where they're just screaming. And really, the first time I saw one, I asked if that person was psychotic, like when I was going through my training, my postdoc, and my supervisor was like, "Oh no, that's full on borderline rage."
Wow.
And it was a sight to behold. And then 20 minutes later, they're like, "Oh, can we do therapy? I really like meeting with you," after they just like screamed at you and screamed at you. So it's definitely hard from a clinician's perspective to work with people who have this disorder. You just don't ever know what you're going to get. Because again, that's so unstable that within the hour you're seeing them, they can just be like up, down, up, down. And they're famous for, as they have their hand on the doorknob, saying, "Oh, and I think I might kill myself," as they're walking out. So then, you have to respond to that, obviously. And that's manipulation too. I mean, they could be really rather than, and that's not manipulation. You have to take either case seriously. But, a lot of times it's manipulative because they want to spend more time with you. They don't want to, maybe they're supposed to go to work. They don't want to go to work. So they come up with these things to say to you that you have to give them immediate and full attention.
Okay.
So, yeah. And then treatment therapy, DBT, which is called dialectical behavior therapy. I'm so sorry. Is evidence-based specialized type of cognitive behavioral therapy, specifically designed for people with borderline personality disorder. It was created by Marsha Linehan, who I had mentioned her book earlier. She later realized that she had borderline personality disorder too, way after she invented DBT. So that's why that book is so good to read. It's considered the gold standard for reducing self-harm, suicidal behaviors, and severe emotional dysregulation. And how it works is there's this very big book that you use they do group treatment usually once a week, individual treatment once a week, and they have, for DBT, they have access. They have they can call you outside of regular. They can call you when they need you, and that you will pick up and kind of coach them through what's going on and try to talk them down, which most therapists don't tell their clients that they can do that, consistently. It's like only if a horrible emergency is happening, then you can, call me at like 10 o'clock at night. Borderline's kind of an exception to that rule. That's part of their all-encompassing treatment, is to have that access to you. Which is one of the components of DBT people like the least, or clinicians like the least, but it's necessary and it's helpful to them and it works. So DBT research shows that 88% of clients who go through the full DBT treatment have reduced symptoms, especially with the suicidal gestures, threats, self-mutilation. And the structure of DBT includes the core skills that are taught are mindfulness, which you usually start out with first. And there's also a huge manual you go through. So there's something we do with clients, and there's a big manual for you too. They're both like that thick. That's incredibly helpful. So then mindfulness is just, they go through three different states of mind. There's mild mind, emotional mind, and wise mind. And you just learn more about what your thinking patterns are and how they relate to your mind. And then you learn mindfulness exercises. And then distress tolerance, which is just learning to manage your emotions and, more about emotional regulation. But mainly learning what to do when you do get that distressed. So that's a big, big component because they are so bad at managing what they do when they get distressed. And then there is actually a module on emotional regulation, which is really starting to help like understand why you're getting emotional, what your emotions are. Sometimes they can't name their emotions. And so there's this really basic handout we give them that has different facial expressions, like a circle with different, like the smiley face kind of thing, but like, with anger and frustration. And they have to go around and name what the different emotions are they're experiencing. A lot of them cannot do it. They just can't tell the difference. And they assume all of them, are bad and means something bad about themselves. And then that's when they get upset. Yeah.
So when you say successful treatment, are you talking about like done, gone, no longer exhibiting bipolar?
75% no longer meet the diagnostic criteria. 75%. So it's really highly effective. It's highly effective. If you have to become certified to do like the whole treatment. Not everyone who does it is certified, but you're supposed to be. Like you go to like a 40-hour or more certification seminars, and yeah.
That's incredibly positive. I feel like so many of these things, it's like, it's ongoing, it's chronic, it's whatever, and this is. I'll go through this treatment and you got a good chance of being done.
Incredibly effective. And then the last module is interpersonal effectiveness, which helps them learn to kind of navigate relationships, how to talk to somebody, how to react when they say something you don't like, things along that continuum.
What's the incidence of recidivism or backsliding? I don't know what the appropriate clinical term is.
Yeah. I don't have that figure in my notes, but that's a good question. This substance is so highly effective to see, well, how long does that last? I'd be interested to see that figure as well. So I'll have to look that up.
This also sounds
like I'm just thinking of movies where like somebody, I've done this, but I've gotten better, and then they start doing it again.
Right. Yeah.
But that's also movies. So
yeah.
I was just going to say, this also sounds very painful for the people who
it is. I mean, they experience a huge amount of emotional pain from disorder.
And I feel like on top of what you're going through, you add in like anxiety, depression, like all these other issues. It's just not a good feeling for the person who goes through it.
Well, and another one of the differential diagnosis that I didn't mention is dissociative identity disorder, which used to be called multiple personality back in former DSMs. And the difference is that people who have DID usually have experience, like it's the rule, not the exceptions, that they had horrific sexual trauma when they were younger, or physical trauma, and they kind of they dissociate to get themselves out of the situation. Like, even though it's happening to them at the time, they dissociate. So it's not like really happening to them. It's the only way they can cope. It's a coping mechanism. But then there are alternate distinct personalities when dissociative identity disorder. I actually only talked to one client throughout my career of 22 years that had dissociative identity disorder. And it was, at first I was like, are they faking? Like, I don't know if this is a lie. I just don't know what to believe, because it's so almost unbelievable that someone could have 8, 10 or more personalities. But they would talk to me and they would have like a different voice for their different personalities, completely different mannerisms, different names, different stories. They would talk about the other personalities sometimes. It was really interesting and difficult to treat, but huge history of trauma. So anyway, back to borderline. So DBT operates on the dialectical principle that two things can be true at once. So the person has to accept their intense feelings while actively working to change their behaviors. So that's the dialectical part of it. It really helps people get healthier behaviors. It helps them start to be able to be less unstable, have more potentially positive relationships interpersonally, more positive view of themselves. So that decreases the fear of like abandonment and rejection.
Mhm.
So it's really good. There are no medications that can treat borderline personality disorder, like in and of itself. They use other medications off label to treat their other symptoms. Like if they have a depressive disorder, they can get like a mood stabilizer or antidepressant. Antidepressants are prescribed the least, but mood stabilizers are the most common, and that would be like Lamictal or Topamax. They also use the antipsychotics too, not because they are psychotic, but because those can be used as an adjunct to depressive disorders as well.
Mm.
And that would be like Seroquel or Abilify are examples.
Mm.
So yeah, a lot of off-label usage. Let's see. We talk about the medication. So then key consideration are that you do therapy first with someone with borderline personality disorder. And then as you start to notice maybe the therapy is helping, the DBT is helping, then you could add in medications. But you want to see what they're like without the medications first. And I mean, I'm not saying like wait 9 months, but like a couple months where you get to know them, you get to see kind of the way their symptoms present, how long they stay, stuff like that. Then cross-culturally, it is a universal disorder. It doesn't discriminate. How it is presented is very different in different cultures. More collectivistic cultures tend to present psychosomatic symptoms. Like they've had headaches and stomach aches are the most likely to occur with the psychosomatic symptoms. And then they don't usually seek out treatment the way that people in the Western cultures do.
Okay.
A lot of that is like, so take the Asian culture, maybe it's, they have culturally they keep it in the family if something, someone's maybe having some mental health problems, or they don't even acknowledge that it's a mental health problem.
So is there a difference between psychomaniac and hypomaniac?
Well, yeah. I mean, if you're talking about like hypomania, that's a bipolar 2 disorder, because there's bipolar 1 and bipolar 2.
Okay.
And bipolar 2 is less severe. Bipolar 1, you have to have a manic episode to have bipolar 1. It's just one manic episode at least, where you only have a hypomanic episode in bipolar 2. So that's why it's like less severe.
Okay.
That's the main difference between the two.
Thank you.
Yeah, you're welcome. But yeah, as far as the somatic symptoms, their emotional dysregulations expressed through physical symptoms. So yeah, I don't know.
So
yeah.
Sorry, I'm just trying to kind of sum it up in my head. It seems like, and please correct me if I'm wrong, borderline personality disorder is really just an intense issue with emotional regulation. Like at its core, it's huge issues with emotional regulation. But not like bipolar disorder, where it seems like bipolar disorder, those issues tend toward one extreme at a time, and then toward the other. Whereas with borderline, it's like it can be anywhere, anytime, everything, everywhere, all at once.
Yeah, that's accurate.
Okay.
Yeah.
No, that makes sense. And I feel like I've known a few people like it.
Most of us have known one or two in our lifetime. Maybe we didn't, like you said, maybe you didn't recognize it at the time, but later you're like, oh, okay. And people throw out the phrase borderline all the time. They're like, oh, she's so borderline. Like when someone's acting like, not their normal self, or change their mind about something. I've heard people say that a lot. And I'm like, that's not what it is. That's not what it is. Don't call someone that.
Oh, go ahead.
I was just saying, they shouldn't call someone that or diagnose them as that if they're not, because it's not a compliment.
I do remember that, like, the person that I'm thinking about that told me, "Hey, I've been diagnosed with borderline personality disorder." I wasn't like super close to them, but the people that were, like, they were constantly concerned, um, you know, because she would have like normal, totally great things, and then she would just go into this spiral where she was like very hard to deal with, very hard to reach, and like certain things just absolutely had to be or absolutely couldn't be, and
Yeah.
there was risk of self-harm and just um but I remember being like, oh yeah, she's cool, and her closer friends being like, oh, but like, we got to be on suicide watch today or whatever, and
Yeah.
yeah, that
Yeah.
was
I mean,
yeah.
their pervasive pattern of instability in interpersonal relationships is, I mean, once you get involved with one, and you're close to one, then, I mean, it will be directed at you at some point. It absolutely will. Um, it's not that they just do it to like one person in their life. They do it to everybody.
Sucks.
Yeah, it does. So cultural impact on key symptoms. I think this is really interesting. Studies show that Eastern nations often report higher rates of self-poisoning, and that's the way they self-harm or try to kill themselves, is through self-poisoning. While in Western nations, they lean toward self-mutilation. So that's like the difference in how they, manifest their desire to hurt themselves. Which I just wonder, where are they getting all these poisons? I don't know. I wouldn't know where to get a poison. I mean, if you drink like bleach or like, rat killer stuff like they showed in 9 to 5, that then obviously would be poison. But like straight up poisonings like, arsenic or other things. I don't know where one would even get those, but who knows what
We'll
they're
say, like, in my Japanese family, like they have a lot of like they'll make their own teas and stuff from plants
Yeah.
that they grow uh in their garden. So I feel like, I don't know if that's a specific to my family thing or everybody does that, but I feel like if you're growing a lot of different plants for, teas and medicines and stuff like that, or home remedies, there's probably stuff that you can access from them that are poisons. That's just my suspicion, but I
Mhm.
don't know.
Yeah. Yeah. Um, well, just to get back to the difference between bipolar and borderline, um, they're comorbid in 18% of cases. So not huge, but still, I think significant. And so bipolar, their mood swings are neurological and autonomous, while borderlines are environmentally triggered and usually come with interpersonal sensitivity, where bipolar does not. How they react when they're depressed. Bipolar is disabled by depressive symptoms. They like don't get out of bed if it's severe. They don't shower. Their neurovegetative states, which are like sleep and appetite, are like the first to go. Like you either start eating a ton or you stop eating. Your sleep is disrupted. You sleep all the time or not at all. Or when you try to sleep, you wake up all the time. And then I talked about their thinking pattern earlier, that bipolar does not use dichotomous thinking and borderline does. It's like all or none, black or white. There's no gray areas with them. And then bipolar lacks depth and it's hard to emphasize with them, while borderline is like deep, intense pain and evokes a strong empathetic response. You generally feel bad because these people are in so much emotional pain that you just want to help them, as fast as you can. And unfortunately, to do the full course of DBT, it's time consuming. It's not like you're going to feel better in a month. It takes a while to go through that full treatment course.
Dr. Tilton, I know you mentioned that one of the main things that affects in your brain is the amygdala. But like, what like in terms of like a normal human being, right, that's going through something like this, like what can you give them as a solution or help, like as in day to day, for their lifestyle, where they can like not deal with this such of a like bad of a disorder.
Yeah, well, I think that's where with DBT, I think that's why they have the component where you can call your therapist. So they feel like they have someone and that person's on their side, um, and can hopefully talk them down and try to head off some of the suicidal behaviors, before they actually actualize. So I think that's really the component of the treatment that is different from many other treatments, is you have that access. And it's interesting to just go to a group, a borderline group therapy instance, and watch them interact with each other. It could be, it can really be something else. And then they yell at each other, and you have to really, as a group leader, have to really like keep an eye on it and have rules that you stick to about behavior in group, because they will push it all the time. So in sense of like, you can't put someone else down. You can't, even like call them names. You can't say they're crazy. You can't, all group rules are that you can't talk about it outside of group, but then something you would see them like in a hospital setting, you would see two of them like in the hallway discussing what was said, or someone else in group and what they said, and like either making fun of it or putting it down or whatever. So you really have to enforce the group rules on a consistent basis. And I would go over the group rules at the start of every single session, and also to tell people that they're free to take a timeout in group with these, because the emotions can run so high that people start to get really upset, and will be crying and getting real angry. So to say, okay, we're going to take a group timeout right now, and everyone take like 10 minutes by themselves, to just try to reflect on what's happening and why you're reacting the way you're reacting to what's going on in group.
And props to you for that.
Absolutely.
Yeah, usually that would be, I love doing group, but that would be one that when it was over, I would just be like, oh, I can exhale. I'm exhausted, but it's over. So move on to the next.
So I have two questions. One, can you restate the names of the books that you recommended? Because I want to make sure that we put them in the description for people who want to read them.
The first one is I Hate You, Don't Leave Me. And it also has a workbook / journal that comes with it, which I think is good too. But it's by Kreisman and Strauss, Kreisman, and then Straus. I mean, it's the only book named that out there, but just for edification. And then Building a Life Worth Living, which is by Marsha Linehan. Sorry. Yeah. And big difference between bipolar and borderline is how they handle conflict. If a bipolar person is confronted with something, they'll usually deny the significance of what was going on, while a borderline person, if they're challenged, becomes so angry and oppositional that's then when the borderline rage comes into play. They will not be challenged because it threatens the little bit of sense of self they have is threatened by that, so that then they just lose it.
So the other question I had was, like, in some disorders and some things that people are going through, there's like enablement where you indulge them and they progressively get worse. It sounds like, but I don't want to say that there's no enablement. It's just you have to be there.
Yeah. I mean, I guess if you're going to enable someone with borderline personality disorder, then you would just go along with them and be like, oh, I know it is like that. And people do disappoint you and things like that. That would be enabling them in a major way. And then, you know, whenever anyone enables someone else, they're not doing them any favors, right? So it's better for them to kind of face reality and learn to handle their emotions. And then again, with distress tolerance, because when they're highly distressed, that's when they cut, that's when they bang their head. You know, and that can have really serious ramifications, you know, and usually, unless they're trying to commit suicide, the cuts are like on your arm, just like this way, this way, this way, this way. And then if they're really trying to commit suicide, it's like big, long this way.
Yeah.
So they know the difference of, you know, how to commit suicide or not, just to cut to relieve the emotional pain. But, you know, you never know. They could, if you cut it into your leg and you hit it like an artery or something,
Yeah.
or wherever, then you misjudged and you're going to bleed out. So, you know, it's
bleeding's still
bleeding, still
bleeding.
bleeding.
And you can always lose too much blood.
Yeah. And a lot of times, people with borderline personality disorder who are cutters will always wear long sleeves, you know, and then they'll tell you, you know, I was cutting last night, and, you know, I'll say, well, can I see? And they'll show me, and it's, you know, looks bad to me. It's, you know, really dark red, and it's not just little light things, it's deep. So it's sad that someone's so upset that they would do that to themselves.
Yeah. So that sucks. And I can definitely understand how being in any sort of relationship, whether it's, you know, romantic, friendship, family, with somebody like that is like essentially you're absorbing part of their emotional pain. Like you have to in order to maintain that relationship. Which cannot be easy, but it's also, you know, like they're going through the whole thing, which is insane.
Yeah, and I mean, like I said earlier, they evoke such empathy on the part of either most friends, therapists, at least in the beginning. Now they can wear out, depending on, that can be worn out by constant expressions of anger, or, you know, the devaluation, stuff like that. If someone's constantly devaluing you, then that would get real old. And you become a little bit less empathetic. So
yeah. Plus, it's kind of like there's a comedian, Taylor Tomlinson, who talked about her diagnosis with bipolar disorder, and how like she had done a lot of horrible things to people before she was diagnosed, but now she's medicated and going through treatment and everything, and sees a therapist, and she talked about how, like, if she hadn't taken the steps to improve where she was, then that would make her the a-hole. And I think that's especially true for something like this, where there's such a high level of success from treatment, where it's like, hey, you know, if I'm a friend with somebody who has borderline personality disorder, you know, I would be like, you need to get treatment. Like, this is not a negotiable, hey, I'm recommending. This is like, you need to get treatment.
Yeah. I mean, you have to be very firm with them about, like you said, the need to get treatment, and the need to actually follow what they're learning in their individual sessions, their group sessions. I mean, sometimes they can even do 2 individual sessions a week in just one group. And then you give them, you know, the handouts from the skills manual, and have them, they do homework outside of group, or outside of your individual sessions. And they usually, in my experience, they've been very, you know, they finish their homework, they bring it to class. So a lot of other people would be like, oh, I just ran out of time or something, which I understand, people are busy. But with my borderline personality disorders, I think they're so unhappy. They're really motivated to do what needs to be done so they can feel better.
Well, that's good. That's kind of like the silver lining behind all this is,
All right.
I guess
Yeah.
you go through enough pain, you find a way to stop the pain, I guess.
Yeah. Mm-hmm. Yeah.
Well,
So yeah, that's all I have on it. But I hope it was helpful and interesting.
no, very helpful. I'm kind of honestly, I'm all over the place. Like there's a part of me that, like I said, I'm thinking about different people that I've met that kind of exhibit these symptoms. And then there's a part of me that's just like, man, I feel so bad for those people. And then there's another part of me that's like, okay, but go get treatment.
Right.
Um,
Right.
you know, there's a
They're not as easy to dislike as people with psychopathy or narcissism personality disorder are. Like they're just so easy to dislike from like day one. Borderline, they have to wear you out over time, and then once you see some of those first symptoms emerge, then you might be like, oh, okay, but it's not always just off the bat.
Well, thank you so much for joining us and for educating us on borderline personality disorder. This was absolutely something I knew nothing about, so very, very interesting. Thank you, Ravi, for joining us as well, and thank you to Lamco Wellness for sponsoring this. And we'll see you next week.
Okay.
Thanks, everybody.
Thanks, everyone.
Bye.
Bye.